Hello my dear friends, in this video I am going to show you a technique, belt loop technique for the re-fixation of subluxated IOL-bag complex. In this technique, create a loop around the haptic optic junction with the help of bent 26 gauge needle and 60 Prolene suture. To create a loop, 60 Prolene suture inserted through the conjunctiva sclera capsular bag posterior to the haptic optic junction, then withdraw the suture through the sclera, what I call belt loop technique. This technique is minimal invasive with little disruption of the conjunctiva. Now we will move on the video of the surgery. This is a case of progressive subluxation of IOL-bag complex because of the pseudo-exfoliation. We can see the white deposit over the pupillary margin. For the better centration, first of all we mark the 2 points over the limbus 180 degree apart with the help of mange ring. Then create another 2 marks 180 degree apart 2 mm away from the primary marks for the inserting point of the 26 gauge needle. In this case, vitreous not in anterior chamber, so no need of do vitrectomy. When you start this technique, you start first on vitrectomized eye. To create a first belt loop, bring the haptic optic junction with the help of 2 dialer in the anterior chamber over the iris. Here we can see the good amount of capsular fibrosis around the haptic optic junction, which is good for the fixation. Now with the help of forceps, one end of the 60 Prolene suture inserted in anterior chamber up to the middle. Insert the 26 gauge bend needle with bevel up 2 mm away from the limbus through the conjunctiva, sclera, capsular bag behind the haptics. Now with the help of forceps, thread the 60 Prolene suture in the lumen of the needle and then gradually, slowly withdraw the needle with the suture. This way you externalize the one end of the 60 Prolene suture. Now another end of the Prolene suture insert in the anterior chamber through the same port with the help of the forceps up to the middle of the anterior chamber. You can use micro forceps or any forceps to insert the suture. Now to externalize the another end of the 60 Prolene suture, insert the 26 gauge bend needle bevel up just 0.5 mm anterior to the primary mark through the conjunctiva sclera and anterior to the haptics. Then with the help of the forceps, thread the another end of the 60 Prolene suture through the into the lumen of the needle, and threading is enough amount so it will not come out while externalized. Here you can see the another end of the suture is also external. Now it's become a complete loop around the haptic optic junction. Same way we'll create another loop around the another haptic optic junction. For that, with the help of 2 dialer, we bring the another haptic optic junction in the anterior chamber. Here you can see the good amount of fibrosis around the haptic optic junction, so fixation will better. Then one end of another piece of 60 Prolene suture insert in the anterior chamber up to the middle of the AC and insert the 26 gauge needle bevel up 2 mm away from the limbus through the conjunctiva sclera and posterior to the haptics, then threading the 60 Prolene suture in the lumen of the needle and then slowly withdraw the needle to externalize the first end of the suture. Now insert the another end of the 60 Prolene suture in the anterior chamber with the help of forceps up to the middle of the anterior chamber and insert the 26 gauge needle bevel up through the conjunctiva sclera and then anterior to the haptic to make a proper loop around the haptic optic junction, and then with the help of the forceps thread the other end of the suture in the lumen of the 26 gauge needle and threading enough amount, and then withdraw slowly and externalize the another end of the suture, and it's become a complete loop around the haptic optic junction. Then you push the haptic optic junction posterior to the iris. Now before create the flanges, we should check the centration and tilt of the IOL-bag complex, because chances is there, if tension on the both the loop are not equal, then chances of tilt and decentration is there. Now with the help of low thermal cautery, create the flanges on the both end of the 60 prolin suture, and take care when you create the flange, you don't touch the suture end, otherwise flange become irregular and it's create some irregularities. Now on other side, create a two flanges on the two end of the 60 prolin suture with the help of the low thermal cautery. Before you made the flanges, you ensure the centration and tilt of the IOL-bag complex, because it is very necessary, it's very important. Now check the OR for flanges and push the flanges with the help of the forceps subconjunctivally as well as little amount of the indus sclera to prevent the suture erosion. And you can see the cornea is clear, IOL-bag complex in the center. Surgery is being under local anesthesia and under the entry chamber maintainer. Surgery is minimal invasive with little disruption of the conjunctiva. No need of peritomy. Incision heals more quickly with less scarring, and we can use the same lens bag complex. No need of new IOL. Thanks for watching this video.